Thank you all for joining us this afternoon. Welcome. This is, of course, the session that we had originally scheduled for the Thursday, the 1st of February, and that session was deferred on account of the weather event which struck Dunedin on that day. So can I apologise to any of you who did make your way to this venue on that day. Thank you for your persistence, and it's a beautiful day out there. Can you hear me at the back? Right. Particularly for those at the back, if you are having trouble hearing, you may wish to move forward. There are seats closer towards the front. So I'm Kathy Grant, the Commissioner at Southern District Health Board. Can I introduce Richard Thompson, Chris Fleming, our CEO, and Lisa Gestro, the Executive Director of Strategy, Primary and Community. But Southern District Health Board is only half of the team here today because we're joined by Well South. We have Doug Hill here as Chair of Well South, Ian Makara, the Chief Executive, and Stuart Barson. So what we're talking about is our primary care, our GP practices, and a whole range of services delivered in the community. Pharmacists, mental health services in the community, home support, Plunket, well child services, and so the list could go on. And in a couple of moments, I'd invite Chris to initiate that discussion with you. But before I do that, I would like to place some context around the strategy. As a Commissioner team, we have met with this community on a number of occasions since our appointment in June 2015. And we have shared with you our challenge, which is to reposition this DHB to a position of sustainability. And so that means workforce sustainability. It means clinical sustainability. It means sustainability as to quality, and it means financial sustainability. And for us as a Commissioner team to be successful, we need to achieve all four. Now, that is a significant challenge because what we are effectively doing is reshaping the health system in this part of the South Island. And what makes that even more challenging is that of all the DHBs, Southern has the largest geographic footprint. 60% of our population live in Dunedin or Invercargill, and the remaining 40% are happily dispersed throughout the region. So we know that as a district, we have the further challenges of distance and travelling time, of access that is sometimes not equitable, of health outcomes for our Māori and Pacifica populations that do not generally match the health outcomes for the rest of our population. And looking into the future only adds to that complexity. The population in Southern, as in many other parts of New Zealand, is ageing. In some parts of this district, the population will remain static. In other parts, particularly the Central Lakes area, there will be significant growth. Our population is also living longer, about 81 years, which is slightly lower than the national average. And in 20 years' time, 25% of the population will be over the age of 65. So if I'm still alive, at that time, I'll definitely be in the grouping of the frail elderly, the ageing baby boomers. And with an ageing population comes growth in demand for health services, for orthopaedic services, hips and knees, for cardiac surgery, services associated with the health of older people. And in contrast, demand for paediatric and obstetric services is likely to remain at about its present level. So we know that if we were to continue to deliver health services as we presently do, there could be up to a 30% growth in demand. Now, that is unsustainable in terms of our workforce. Where would the additional clinicians and nursing workforce come from? Those clinicians would need to have started their training now. It's unsustainable in terms of physical resources. It would require a huge increase in the number of beds in both Dunedin and Invercargill. And it's unsustainable in terms of cost, both for this DHB and for the community. So the current model will be unable to deliver in the future. And if we continued with the present model in relation to primary care, general practice would drown. So what does all of this mean? Well, it means that we need to change the way in which we deliver health services. And while this afternoon we're focusing our discussion on primary and community services, exactly the same discussion is happening in the context of secondary services, the services that to date have been delivered in a hospital context. And that analysis is being undertaken in the context of the rebuild of Dunedin Hospital. So what we are challenging are the expectations as to what our health system can deliver and how it in fact delivers. So the discussion today doesn't sit in isolation, it is part of a bigger picture. In 2000, just going back to 2016, we spent time engaging with the communities in this district to establish their expectations of a healthcare system, what we referred to as the listening weeks. And we asked the question, if given the opportunity, what would be the one thing that you would change about our health system? And we received over 3,000 pieces of feedback, and there were some pretty clear responses. The clear response that people wanted to wait less, and for our rural communities, they wanted to travel less and have care provided closer to home. Now, those responses have been reflected in this draft strategy, and so we are absolutely focused on doing what is best for our communities. Now, I know that change can be challenging, but Southern is not reinventing the wheel. And the strategies which reposition primary and community care are a successful feature of other DHBs. An example is provided by our closest neighbour, Canterbury, and at the other end of the country, Northland, which, like Southern, has a large geographic footprint. So the concepts which underpin this strategy are working elsewhere in the country, keeping people healthier in their own homes and out of hospital. And so in that sense, Southern is catching up rather than setting the trend. I would make the comment that in proposing our draft strategy, this is not a slavish adherence to someone else's model. Our strategy has very much a Southern lens, and it is all about what will work best for our communities. So, yes, we have a strategy. It is a draft, and we're coming with an open mind. We need your feedback and your comments. So really the most important part of today's session is really to gather that feedback and for us to have the opportunity to answer your questions. So I'd like to think we could allow good time for questions, comments and discussion. Chris, perhaps to take over.
We're going to talk to you about the primary community care strategy and action plan. And so welcome. In terms of the approach that we're going to take today, we're going to firstly talk to you about what was the need, why have we developed the primary community strategy? Secondly, how have we developed it? What is the strategy and the goals, and what does it mean for you? and then how are we going to put that strategy into practice. And as Kathy said, it's a draft, but one of the things that both Kathy, the Commissioner, and Doug Hill, the Chair of the Primary Health Network, has said to Ian and myself is, if we go out with this strategy, if the feedback is positive and supportive of the direction of travel, we're going to hold you two jointly to account to make sure you now go ahead and start implementing it and keep working through it over the coming years as it unfolds. So firstly, why did we need the strategy? And in terms of getting ready for these presentations, Kathy said to me, you're not to present just a list of strategies and goals and stuff. You need to make it real, and we need to relate it to people. And so we developed Margaret, and I apologise. Margaret is an elderly lady, 82-year-old. She lives alone. She's a widow, lives alone. Her children live overseas. She's got some hobbies: reading, playing bridge. She's still reasonably active in terms of able to take short walks. She's got a small group of friends, and she's not a technophobe, but she's not a techno guru. She prefers to use a phone, but she can use a computer. I'll just point out, we know that not everybody is an 82-year-old white lady in Southern. And the needs of Margaret and the needs of our younger population, the needs of our Māori population differ. We're relating it to Margaret, but equally we need to relate our strategy and action to make sure it fits for all of our population. But we are going to use Margaret as the example. Margaret, her health conditions is not unsimilar to many people in the elderly population. She's got high blood pressure, she's got arthritis, she's pre-diabetic, she's had skin cancer problems attributable to side effects from her blood pressure that she needs treatment on. And Margaret, like many of us, has a whole cocktail of health professionals that she interacts with. Her trusted GP, community laboratory, practice nurse, community pharmacy, physio, and a whole range of specialists, many of whom don't talk to each other, and also her dentist. What does she think about the health service? She feels that she's passed between services. She feels that she has to be on top of things. She has to follow up around follow-up tests about her appointments. She's pretty grumpy that services don't seem to talk to each other, and that every time she interacts, when she comes into the hospital, she has to tell many people in the hospital her history for the one visit, but she also has to repeat that to the home and community support provider and to her GP, etc. Nothing appears to be shared. And like many in our population, Margaret doesn't like to complain because she understands the health professionals are very busy and are doing their best. But actually, she feels like she's being given patchwork treatment in terms of her health system, health services and her access to services. And so we're going to come back to Margaret and say, with the changes that we want to drive in both the health and disability services in terms of moving forward, what might that mean for how it will be different for Margaret as we go through? Why did we develop the strategy? Well, firstly, and Kathy's already alluded to it, within the next 20 years, there's going to be a 25% increase in our population over 65. That has huge implications on the health system. I'm responsible for the health outcome for all our population, and yet we live in a society which sees that Māori die 3 times more frequently for things that should be addressed in health and disability services. We have the second highest utilisation in aged residential care in the country. And that's not because we've got an old population. That second highest utilisation is age standardised. So we've historically put people into aged residential care at a much faster rate than anywhere, with the exception of the west coast of the South Island, to any other part of the country. Not good for the individuals, and also not good in terms of demand and utilisation of health resources. over the last 3 years, ED presentations across our district have gone up 33%. And it's only going to keep going if we don't do something differently. That means 56 more people turning up at ED every day of the year. I've just signed out a media statement because the media is asking questions about ED's busyness today. 56 more people turn up to ED every day of the year than did 3 years ago. And then, whilst this is focused on primary and community, and the last column about our workforce is very much about general practitioner workforce, the same is true in many other disciplines. 40% of our GPs have indicated they intend on retiring in the next 10 years. And over the next 20 years, if we just keep going, the demand for GP attendances will increase by 73%. Now you can add the two together, 40% plus 73%. The scary thing, but also the exciting thing is this is not about just tipping a little bit more money in, because even if I could find the magical, mythical money tree, I would not be able to find 113% more GP to replace the GPs in the growth in demand. And that's going to have the same impact across many other health and disability services that we're providing. The other reason why expectations are changing, 10, 20 years ago, we all just sat there slavishly and accepted what the doctor said. Doctor knows best. Actually, our expectations are changing. We expect patients, family and whānau, expect their care to be more consistent, regardless about how they access the services, and they expect to be playing a much more central role in planning and coordinating their care. They want to be involved. They don't just want to be a bystander to their own healthcare delivery. And so what we need to do in terms of developing our strategy is we need to get the three components there. We need safe, robust, high-quality secondary and tertiary care, having that available for those of us who need it at various stages of our life. We need to have strengthened primary and community care services. We need to integrate those services so that we're meeting the needs of our community. And yes, we also need to encourage and enable and empower more self-care. All three of those have to be successful for us to be able to have a sustainable future. We've also developed the strategy because these statistics, we used Ernst & Young to help us develop the primary and community strategy. These numbers are not Southern specific. They are the result of a survey that Ernst & Young did nationally, but we have no reason to believe it doesn't apply in Southern as well. And so on the left-hand side, 3/4 of our population turn online for general research and information about health issues. Half of our population seek information for diagnostic purposes for either themselves or for other people. I'm not saying when they seek it, they get it right. I'm not saying that they look on the internet and get information and it's always the right one, but that is what people are doing. And 1/4 of us actually go onto the internet to figure out what we need to ask our health professionals when we interact with them. Once again, half the time those questions won't be the right ones, but we do go to that. Then moving on to the right-hand side, in terms of digital tools and technologies to enable better management and coordinating healthcare. More than 80% of our population say they want to access test results electronically and in an understandable format. So that's two elements, electronically and not in medico mumbo-jumbo, but language that we understand. 3/4 of our population want to use digital tools for reminders, for self-management programs, etc. And about 3/4 of our population say they want to use phone apps and tablets and devices to store personal records and data. Now, the reason why we're labouring on this point is that those are significant numbers. And in 10 years' time, if I did the survey again, I'm sure where it says 80, it will be 90-something. It will never be 100. And even today, for each of those ones, 81% accessing test results, that by default means 19% either can't, don't want to, or can't afford to. We have to develop our solutions in primary and community to recognise this need, but also not to leave, if you happen to be one in that 19%, behind. We have to have the system that will work for both. Another reason why we're developing this strategy is because actually people want to get their care closer to home, and accordingly we want to resource needs to be prioritised away from pouring all the health dollars into the hospital and stretch out our investment into primary and community. The blue bar graphs represent roughly the dollars that we spend in each of those components. For every individual patient that goes into hospital, that is admitted to hospital, it costs about $5,000, somewhere around that. For every individual who interacts with and engages in primary care, both the funding that goes in from the government and our own contributions, it costs about $100. You can get significantly greater reach from our investment in terms of investing in the public health, individual prevention, long-term, and avoiding hospital admissions than we can get from if we just keep pouring more and more money into the hospital environment. It ends up being good for the health system in terms of bringing it up this end, and it is also good for each and every one of us if we get the balance right. The next bit is about why is because it's timely, and it's a very apt audience. We're in Dunedin. Dunedin Hospital is about a block away, so clearly the rebuild of Dunedin Hospital is very pertinent and relevant for people that live here, but it is just as pertinent and relevant for people that live in Cromwell, in Queenstown, and Te Anau, Elmaru, etc., because the rebuild of Dunedin Hospital gives us a great opportunity. We are going to close Dunedin Hospital and open another one. Where, we're going to find out soon. But it's not often you get a generational change that results in such a major investment. And when we're making these major investments, now's the right time to be able to make sure we are investing at the right places to drive the health system forward. And our indicative business case, which has been signed off, articulates that investment in primary and community services is vital for the success of Dunedin Hospital. And I'd advocate it's vital for the success and prosperity in the Central Lakes area and in Invercargill as well. And so let's leverage the opportunity of this major investment in Dunedin to affect how services are provided in an integrated way right across our health system. How was the strategy developed? I read somewhere that it was developed by us sitting in a dark room. That's not the case. Yes, we have had external support in helping us develop the strategy. We contracted Ernst & Young to contribute to that process for us. We've effectively taken two components. Firstly, the research approach in terms of looking at key national, regional and local strategies and plans. We've analysed the profile of our Southern District, and then we've engaged quite extensively, ranging from consumer focus groups, in-depth interviews, wainanga, online forums, road shows, where we came out and said, this is where we're thinking, are we hearing you right? And then built that feedback into our planning. We've had Community Health Council input into the steering group. I recognise Martin from our Community Health Council there. And we've also built on from the listening sessions that happened as a part of the Southern Future work that Kathy's referred to. We've had huge numbers of people involved in our process, and we're quite proud that we've really balanced the research to also what people are saying. So what is the strategy? So firstly, the Southern Health System. Now what is this mythical Southern Health System? If you are a part of providing health and disability services in our community, you are a part of the Southern Health System. It is not Southern DHB, the Well South part of Southern Health System. The NGOs are part of Southern Health System. Aged residential care is a part of the Southern Health System, as is Dunedin Hospital. So better health, better lives, whānau is the vision, and that was the vision before we started, it's the vision still. Then in terms of primary and community care, we reflected long and hard on terms of what do we want the system to do, and we're being bold and we're saying it as it is, which is that we want it to empower people to live well, stay well, get well and die well. it's a fact of life. That's what we're all going to do eventually. And actually what we want to do is have the health and disability system supporting right across the continuum of life to enable that activity through integrating ways of both working and the use of technology. It's not about just putting in a smart computer and saying we've fixed the health system. It's about enabling it with technology and integrating the ways we're working. So there are four, the strategic goals are not voluminous. We don't have a strategy with 25 strategic goals that mean that you won't be able to hold us to account to make sure we deliver on what we say we're going to do. There's only 4 strategic goals. The first one being about consumers, family and whānau, and communities being empowered to drive and own their care. The second is about how primary and community care works in partnership to provide team-based care. The third one, this is a primary and community strategy, but the third one is about secondary and tertiary care being integrated into primary and community care models wherever possible. And then the last one is about enabling the system through appropriate technology-based healthcare systems. So the first strategic goal, what does that mean for you and your family whānau? Well, firstly, we want to drive it so that you have a more personalised overall experience, that there's a shared care plan that you're involved with. You and your family can be involved in developing, not just something that a health professional develops and tells you you're involved in it. We want to ensure that you have access to information to help you stay well. We want you to have increased choice. Now, I'm quite upfront about this. It's increased choice. It's not free absolute choice. We live in a rationed health system. We will always have to make some tough decisions about where we invest. Wherever choice is possible, we want you to have that choice. Looking at the Māori statistics and understanding that the outcomes for Māori are less than for non-Māori, we want to, wherever possible, have culturally appropriate services, particularly for long-term and ongoing chronic conditions. That we enable each of us to have a key contact within our healthcare team, that you can actually contact electronically as much as in person. And if you're like Margaret and you've got long-term chronic conditions, that person will also be your key contact for coordinating the services that you need to access. And then also empowering the system to mean that you can be plugged in to connect with others in your region who have similar conditions and similar issues as yourself, so you can actually support each other through the challenges. Moving to the second goal of primary care working in partnership. Now this slide and a couple other slides are kind of a meaty part of the strategy. And I'll introduce the 3 concepts. Firstly, the healthcare home, the community health hubs and the locality networks. Now the healthcare home is your general practice, or is and will be your general practice. But it's general practice organised in a way that enhances patient care experience, that builds on relationships with the community, hospital and specialist services, and it is quite likely to include rehab, rapid response services, some outpatient activity, etc. And I just kind of paint a picture of a healthcare home a little bit like my own home. My own home is something I know well, I like it, I'm comfortable in it. I have responsibilities in my home, my wife has responsibilities, my children before they left me, they had responsibilities. And those responsibilities will be different in my home than they will be in Kathy's home. Because in Kathy's home, there's different skills and different strengths and weaknesses within that family. Same is true in your healthcare home. It is a place that you know and trust and you view as your primary care or service, health services access, and there will be people within that home that will be there to do different components of care. Not the traditional primary care where you have to go and the person you see is your GP all the time, but actually you're using the nursing, using medical staff and allied health to optimise care. How many healthcare homes will there be in South Canterbury? God, that was 10 years ago. How many homes will there be in Southern? At the moment, there's 83 general practices. I don't know how many there will be in the future. There'll be many, maybe 83. Community hubs are broader. There will be fewer community hubs that provide physical infrastructure to enable more integrated ways of working. And when I said there's 83 83 general practices, I'm thinking there will probably be maybe 3 community health hubs in Dunedin, a couple in Invercargill, and the rural hospital networks will provide the infrastructure and the base for community health hubs, most likely in the rural settings. So many healthcare homes, a few community health hubs, which healthcare homes will relate to. They'll be able to provide more scale and scope to be able to provide services depending on the population size. The expectation that some of the services that will be available in community health hubs will be there for longer hours, shorter waiting times, better planning coordination. And then getting even broader locality networks. These will be where health and disability and social agencies will collaborate together in terms of planning and coordinating services across that broader region. So lots of healthcare homes, smaller number of community health hubs, and even a smaller number of localities. Dunedin, I would be expecting, would be a single locality. So large, smaller, smallest. What will it mean for Margaret? Firstly, expectation that she will have a greater say, not absolute free will, as I pointed out earlier, greater say in how she wishes to receive care and planning. Members of her team, her primary care team, are more likely to be able to spend more time with Margaret, but because we're empowering and enabling electronically, she'll probably have to be in the practice less often. She will have more influence and control over her care, and she can contact her key worker in between face-to-face activities as she wishes. She'll be able to make appointments online, and she will be able to have access to her own notes. Now, some Margarets will be able to have access to her own notes and understand. Some Margarets won't be able to and will choose not to. But Margaret will be able to have access, and she'll be able to share that access to her electronic health record with her family, if that's what she wants to do, to enable them to be more involved in helping mum plan and access her services. So a different way of portraying the healthcare homes, the healthcare home, community health hub and locality networks. Healthcare home in the middle, the light blue bubbles being the types of services, and I'm saying the types of services because some of the dark blue bubbles might choose to be a part of a community health hub, but we would expect to see mental health and addictions, pharmacy, primary care and urgent care, community health services, radiology, blood, minor procedures, and we would expect to see some of the visiting specialist services for which you currently have to travel into the hospital to access, being able to be provided out of the community health hub. The broader locality network, as you can see, there is a whole range from aged residential care, home and community support services, kaupapa Māori services, hospice, social care, hospital, maternity, St John's, community pharmacy, etc., being in the locality. Another way of looking at just putting volume and scale, the green circle was a locality network, one locality, and that in this mythical locality there are 3 community health hubs, and you can see there are multiple healthcare homes of different sizes. Where do we think the localities will be? This slide says this is where we thought before we went to the first engagement session in terms of a presentation like this, and we very quickly changed our mind about where we thought the localities would be in some aspects. We had a session early on in the central Otago area, and by and large the general feedback from Wanaka, Queenstown and central Otago is that they think they're one locality. At the time we started we thought there'd be 3 localities. They think there should be one locality with a number of community health hubs within that locality, but we broadly think that's where the localities will be. They're localities of common population, common interest. And you can see the sort of scale with obviously the locality of Dunedin having the larger number of general practices with 29 presently and around 109,000 people. Doesn't really matter if these boundaries of these localities are perfect, because how we go and develop the localities and engage with those communities, that will heavily influence where things go. So what does it mean for Margaret in terms of a different way of showing this? So Margaret, her health information will be fed in through assessment information like Intri and other assessment tools. It will be fed in, and a care plan will be developed with Margaret. That care plan will then be given to a care delivery team. Those roles in that care delivery team are just by way of example. There's one that's really missing there for Margaret, given that we know she gets home and community support services. Her home and community support service provider would also be a part of that care team. Whatever is appropriate to deliver the care for Margaret. There'd be case conferences about Margaret's care and how she's going, care review and fed background into the care planning, which Margaret would once again be actively involved in influencing and designing. So more proactive outreach from her general practice team, fewer tests and assessments because we're going to share information. It's a complaint quite frequent. You know, I've had tests in primary care, then I come to ED and they do it again. Well, actually, we should be using that information and avoiding unnecessary tests and duplication. She'll have her ability to access her practice team by phone or email if she's just unsure about something. She'll get to be able to spend more time with the nurse working on goals to stay well rather than focusing on the 15-minute GP appointments. More care being provided closer to home, which will mean that there will be fewer trips to either Dunedin or Invercargill Hospital for that care. And because she's got access to the online resources, support groups and community-based care providers, she will gain an increased level of confidence. Now moving on to locality, the third goal of secondary and tertiary care being integrated. What will that mean? Well, what it will mean is we want to drive an ability for specialists to be able to provide more support to the primary care team in a real-time situation. I don't know how many times I've heard complaints about we're referring patients to you because we couldn't have a 2-minute phone conversation, so therefore we refer. We spend time waiting and eventually, sometimes you get a letter saying we won't see you. Whereas actually a phone call to the specialist services to get that access to information. We want to challenge our workforce. So some of our team members who are traditionally hospital-based to form a key part of the extended primary care team and most likely going to be located out in the community health hubs. Why are long-term condition nurses located in a hospital when you have your long-term condition in the community? You don't have it in the hospital, so we should move resources like that out into the hubs. Why is needs assessment services staff in the hospital? Move them into the hubs. What about district nursing? What about, you can then just ask questions, what about? And pushing things out there where it makes sense. So the community health hub won't be an organisation. It won't mean that those services aren't provided by the DHB, but a community health hub is where services that are going to support the wider community services can be co-located and work together. We're going to encourage specialists to deliver clinics in the community more, either by way of telehealth or in person. With 83 general practices, not a chance I will get specialists to go and provide specialist clinics in 83 practices. When there's 2 or 3 community health hubs in Dunedin, much more viable to get services moved out to being closer there within that sort of model. Single clear point of access for primary and care providers to get rapid advice. And then in the event of people actually needing to be admitted to hospital, I haven't found who wrote the rule that everybody needing to be admitted to hospital has to come to ED. I've asked for someone to show me where that rule came from. Nobody can find it because nobody ever made that rule, but that is the rule. If there's relationship between primary and specialist care, if the hospital is the appropriate place for you to be, my expectation is we'll change the system so that actually referral from primary care directly to their appropriate clinical area will be possible in some of those circumstances. Wherever possible, we also want to tailor the services to meet the needs of Māori, because at the moment the way we deliver services aren't meeting the needs of Māori, and locality networks will influence future secondary services. I got asked a very pertinent question in Oamaru. Mr. Fleming, why can I have a neurosurgical clinic in Oamaru, which I really appreciate being able to have, by the way, but why can I have a neurosurgical clinic in Oamaru, but I can't get any dermatology advice to save myself? And the answer is, I flippantly said, well, maybe there's never been a march up George Street for dermatology services, but it is because that is a historical decision making. Why have we got the best access in the country for cardiac services and access to primary mental health services is pretty poor? Because that's how we've historically made our funding and our investment decisions. We want locality networks to start influencing how we prioritise where we invest, rather than historical funding mechanisms or the squeakiest wheel is where we go. So we want localities to influence both future secondary services and also how we prioritise the investment in primary and community services moving forward. So for Margaret, she will still need hospital-based specialist care, but our expectation would be that it would be less frequent because there's more services out in the community, and her stay will be shorter. There are patients lying up in Dunedin Hospital at the moment because we do not have enough access to community allied health services. We need to fix that. So by moving more services into primary and community, we will be freeing up resources from the hospital, and actually everyone that's up there waiting for community allied health services, they really do want to be home anyway. So it's good for the patient, good for the organisation, and it actually is much more cost effective. Required tests, we should be able to rely on blood tests and x-rays done in primary care being reviewed in secondary care rather than being repeated, which is often the case. And depending on her requirements, she might get to see the nurse specialist when the GP starts to become worried about her ability to be able to stay home and does she need more support. Telehealth consult, particularly around things like her skin treatment. And while she'll still need to come to Dunedin or Southland occasionally, she'll have more influence on being able to make the appointments. Often complaint from people in Cromwell, why do you send me appointments at 8:30 on Monday? And even worse, you send me one for 8:30 on Monday and one for 2:30 on Wednesday, because our services don't talk to each other, remember? So actually, wouldn't it be better if in this model we say you now have access for these clinics here, go onto this portal online, you book the clinics that fit for you, so you can coordinate, make it the right time and place for you. And coordinating care between primary and secondary will be easier because of the access to the electronic health record. Moves us on to the last strategy of the health system being technology enabled. So talked about the electronic shared health record. We are not planning on implementing one super magic program, one big major piece of software. Electronic shared health record. Health One is the start of that, and it's about plugging information in off the various systems to mean that access to that information is available at the right place for the right people. Providing more options for virtual consultations. We want to drive down the pathway of supporting new technologies such as in-home sensors for people like heart disease, dementia. I've used my example of my wife, insulin-dependent diabetic. She now has a patch on her arm and it gives her blood sugars constantly. I know what her blood sugar level was at 11:47 last night, even though I was sound asleep. It's much easier to be able to manage diabetes through the use of that, as it is with many other technologies. So we want to encourage that and make it more accessible over time. And better behind-the-scenes technology systems to support shared planning, admin and health systems intelligence. So what does that mean for Margaret? Well, what it means for Margaret is that instead of that she'll be able to regularly Skype her practice team for advice. She'll have apps on her phone that will be, her practice nurse will help set up to encourage her to do things like falls prevention and other issues. Telehealth appointments means she won't have to go in as often. She'll be able to use the online booking, and with her permission, we make a presumption that she'll want her daughter to be able to have access to her shared care plan, but it might be her bridge partner. It's whoever's appropriate for Margaret to be able to have her involved, her trusted people involved in her care planning if she's got any issues.
Chair of Well South Primary Health Network, who leads primary care delivery in the southern region, but I'm also a full-time general practitioner. And so as a GP I look at this and I think this is the way healthcare should have always been designed. This is what I look at, because I look at Margaret's situation and I think, it is like a patchwork quilt at the moment, and all of us working in the system recognise that it's a patchwork quilt, but we can't do anything about it. We're too busy just trying to patch the quilt to actually do anything about fixing the quilt. And this starts to change the whole system so that we can fix the problems that are there. And the huge amount of wastage that goes on, both of medical professionals' time, but also our patients' time, and travel time and everything related to that that's just wasted in the system at the moment, and it's just a huge loss to everybody. This is one of those rare situations where we get a win-win. For patients, this will make a huge difference to their care. They'll have much more control over their care will be more structured, and they'll have much more availability at the right time for the right care without having to travel large distances to do it. There's nothing more frustrating in some of my practice when my patients travel from Balclutha to see me for a 10-minute appointment, and they travel an hour to an hour and a half to come in, spend 10 minutes with me, and travel another hour and a half home, an entire half day off work to spend 10 minutes of my time, when we could just do that over a video conference. And this sort of change is what's coming. As Chris said, we've got to be careful we don't leave people behind who aren't able to have access to the technology, or aren't able to use the technology. But the expectation here is, because of the capacity that we can increase, that will increase in this, that people who can't use the technology and have to use the old system will have more access as well, because we'll have created that access by using this technology for other people. So I think it's an exciting time, and I think there's some scary parts to it, and it's going to take some time to get there. We're not going to wake up one day with it all solved. But over the next little while, we expect to see this going well into this way, and I think we'll find that it's a vastly different and better system for it.
Thanks for that, Doug. We are looking for feedback. We're going to stop now and open the floor up for questions.
When I read through both the strategy and the action plan, I think there's a level of social capital and health literacy assumed. And I think that the marginalised people or members of our population don't actually possess that.
Yep.
So I'm wondering whether alongside all this there needs to be a robust proviso to actually help those people who don't actually possess the level of health literacy and social capital that I think is implicitly assumed in this particular strategy.
Yep.
I don't think it's confined to Maori. I think Pacifica.
Yep.
I'm thinking about mental health and disability community and stuff like that. And I think if you were to put alongside this particular thing of an anti-marginalisation sort of strategy, it needs to be reflected both in the workforce development strategy and the digital strategy, because when you look at our Maori and Pacifica workforce, it's sort of lacking.
Yep. Okay. I take that on board, and indeed we are in the process of developing a workforce and a technology strategy to complement this, and I think that's something that we need to take forward.
to GP, it's private cost.
Yep.
If you're on benefit, or if you're on very low income. Now, there's a wonderful system set up in this town called GP Link. We actually trialled in Timberwell during your tenure.
Yes.
And it went very well. It entailed free access to the GP. Anytime you wanted to, anytime in places, anywhere you wanted to. It was funded actually, it was a combination of the PHO and income support. Very simple system. I wondered why that stopped, because that allowed these folks free access to their GP.
Yep.
So I know from the view that no one goes to the GP for that.
Yep.
And I wonder if that's not again. That would be very significant.
Thank you. I'm Ian McCara from Well South, the Primary Health Organisation. We do actually have, still running, a voucher program where it's not means tested, but it's a means of supporting people to get into their practices and to see a clinician when they can't afford it. So that's been running since the PHO started. So it's still going. I'm not familiar with the Health Link system you're talking about, but we still do have a system running now.
What it was, the personal assets was through their GP over the next 6 months.
Oh yeah, yeah. We
Income support will then pay that GP for those who
there is another.
they didn't take away the or maybe more. Income support will actually pay that from the disability line.
Okay,
It wasn't free, but it was actually part of their disability line.
right.
I think it was an excellent system. It was fine. One of the problems I was made is people put people on the system and never actually took them off. So they're there for life. You know, with no oversight of the system, it was very well intended, I can tell you. I wonder whether we could look at that again.
Yeah, we do have, in addition to the voucher system, there are 2 or 3 other systems in the PHO where patients who have qualifying criteria get access. I mean, Care Plus is a program that's run for a number of, and that's a subsidised visit for 4 visits over a year. So that still runs. And if you're a mental health patient, you actually, get your consults at general practice. There's no cost for those consults as well. Yeah. That-
Yep. I think that's some of those sorts of things are the conversations that can take place within the locality networks. We can have a look into seeing if that program still runs in Timaru and see how it's funded. But it is you actually pose an interesting challenge, and it is a challenge about saying, how do we change funding models over time? I interact with my GP electronically. In the past, I would have gone in physically and paid them. Now I don't pay anything. I go, if we're moving to more models of electronic thing, how do we modify the behaviours to make sure that actually, I would much rather electronically interact with my GP if I can avoid having to physically go in. And I'm quite happy to pay. And I'm in a socio-economic group that's fine. And how do we make sure we don't introduce solutions that work really well for me and not really well for the people who are higher needs and are lower socioeconomic? We have to make it work for all. Yep, and then we'll go to that, then we'll go over there and then there.
Just to say, I'm a being beneficiary of the International Health Service of the Learning for I've been in New Zealand for 20 years and I'm just with health providers. I see a lot of debt among those families that is now. And I think it's a wonderful idea. I'm currently in Motel.
Yep.
I think it'd be a wonderful idea for the Welsh families to live
Yeah. Completely agree with you. And if every absolutely well child should be plugged in, and you bring out the British, the NHS, and having a sister who has up until recently lived in the UK and worked within the NHS environment, actually general practice being free in the NHS creates different dilemmas because people do go there for just social reasons, and so it's so there's some really great things about access when it's free, but there's other unintended consequences. And how do we get a balance, a good balance of both? Barbara, and then that lady, then Barbara, and then this chap in the back here. I thought you were going with someone down there, so just go in the line. And
I was looking at the urgent care demand in the local reg, which is what you presented today, and there's 33% increase in presentations to the emergency department in the last 2 years. So that's huge.
Yep.
And if I sort of ask why, one reason, and I'm sure it relates to what was gentleman saying, it's so jolly expensive to go to the GP. And I know there's going to be some reductions coming along soon, but I think for a lot of people, even $10 is a lot. The other thing is it seems to me, it's the quickest path to see a specialist. And that
Yep.
should be so, but that is what it is currently. Now, with that increase of 33%, does that include tourism? Because we have really had a huge increase in tourism in the last
Yep.
15 years. And it's going to increase more. And in Dunedin alone, to have 2 cruise ships in, that must increase
Yep.
the amount of demand on the emergency department.
Yeah.
So I just wonder if those figures are included in that 13%, or if we're actually thinking of the future when we have tourist boats going to so many ports and they are making taking off ships as
Yeah.
well, plus they're just passing through. So I think tourism is a big thing to be considering. And related to that, are they charged? Because when I travel, I have to have my own private insurance and I'm charged before I leave the country and I can't leave before I pay.
Yeah. Okay. Look, you've got 4 questions in there in one. Firstly, absolutely, cost is an issue, but there's quite a lot of disparity in terms of access to ED across the district. Lesser level of access to ED, lesser level of presentations to ED in Dunedin than there is in Invercargill. It's quite significantly higher in Invercargill, and that's history, and it's not only people. It's not only the proportion of people that can't afford to pay to go to the GP that turn up in ED, particularly in Invercargill. Secondly, you've caught out the other game that goes on, which is instead of writing a referral and running the risk of it being sent back, just turn up to ED and they'll see you. Okay, so yes, absolutely. Is there elements of that? Absolutely there are. So that's why strengthening the relationship between primary and specialist care is part of that driver. Thirdly, the volumes, yes, they do include tourists. And fourthly, depending on where the tourist comes from. So just like if you turn up into if I was on holiday, my wife needed access to health services in the UK, we turned up at the ED there at no charge because the reciprocal arrangements. If you come from America, if you come from Brazil, there's a whole range of countries which are listed. Yes, you are charged, unless there's a reciprocal arrangement in place.
And helicopters also?
Unless there's a reciprocal arrangement. So a British national that turns up, just like if a helicopter is required for you in Britain, you won't be charged if it's an acute service if you're a New Zealand citizen. Likewise, reciprocal. But for the people that don't come from those countries with reciprocal agreements.
And is there a system in place that they must pay for?
Well, that is where the tensions exist, because from a ethical, I'm quite proud that, like, if you turn up in America and you don't have insurance and you can't pay before you get your treatment, well, you're on your own. We choose to live in a society which is perhaps a bit more different moral settings, and so therefore we treat everybody acutely. If you can't pay, we won't carry on treating you electively, or we will send you home. But we do not preclude access to care because you can't pay if it's acute.
I'm actually asking currently,
We,
if they're treated,
yeah,
are they obliged to pay for the leave?
they are obliged to pay, but do they? Not always, no. And so we do follow up, and we've got mechanisms in place. And of course, we have bad debts from people who don't pay, but that's a national challenge. And yeah, Barbara, then you, then you.
Hello, I'm Barbara Burnsley. I want to ask you, this electronic age that we're in,
Yes.
don't have anything to do with.
Well, you do. You're just talking into something.
Second of all, I just find that the personal approach is what I like.
Yep.
And if you're going to talk to your GP,
Mm.
Chris, and he can't see what you look like, as far as I'm concerned,
Yep.
I need to look at the person
Yes.
before I treat them.
Yep.
Yes.
And
so
that.
do these electronic systems break down? You know, I can stand on it.
Well, that is why we talk. I'm picking that you might be in the 19%, not the 81%, and the intention is that it has to cope with the fact that you do have different preferences than me, than Ian, and so it isn't. We are not putting a system in place that says you must now engage with us electronically. You might choose not to, and I choose to, and absolutely, technology, that is one of the biggest challenges, is about how we make sure the technology is reliable. And hence, at the moment we're talking about telehealth to other community health centres. Eventually, when technology becomes reliable, maybe we won't need to go through that level. But at the moment, when telehealth is being used, we have to have confidence that if it's going to be you on the other end of the line, that you are supported to get into it, and that equally, from a utilisation of health resources, there needs to be the reliability. So it works in the supported environments at the moment, but it will keep changing.
Hi, I'm Dr. Veronica Carr. My question is about how does the private system fit into this picture? The challenges that we face from the funding model perspective. We feel like we've been forced in the past 10 years to access more private care and even pay for it out of our own pocket or through health insurance premiums that are skyrocketing and are not sustainable, use the word sustainable, are not sustainable as you age. I don't understand how that fits into this
Yep.
picture.
Well, look, what we do need to be very clear on is that these changes that we're proposing in the health system, if services are available free at the moment, we expect those services to continue to be available free. We do expect, however, that we will have to be challenged about how the implications of change. So, for example, I've used the example of my GP. I go face to face, I pay the person, I want more electronic interaction, so I might need to be prepared that I have to pay for some of that. How the private system provides other options and alternatives, and I think the systems need to make sure that everyone's informed about the options and that it doesn't become an expectation. So, when I access private services, I might choose to access private services, and that releases that resource that would have sent me publicly for someone else. That's a choice, and if it's a choice that I make, that's good, not if it's an obligation on me. So there's no...
But is it a choice if you're not actually being able to get access to the public system?
Well, but that goes to the maturity of having fundamental discussions and debates about where the priorities for the Southern health system are. Why do we fund neurosurgical services and we fund very little dermatology services? We do that because that's how it's been decided over times gone by. When we change things, when we improve things. If we, I know in secondary care we follow up a whole lot of people who should be followed up in primary care. And if we do that and we release resources and invest some more resources in primary care to enable them to do it, if there's overall resources freed up, we need discussions with our localities about, do we then improve access to ophthalmology services, to orthopaedic services? Do we reduce the cost of access to primary care? Do we invest in primary mental health? We need to have the discussions within the localities rather than just arbitrary decisions made without the engagement of those locality groups. We do live in a rationed health system. We always will. You want to make a comment?
Well, I just want to add to that because I think
I mean, we're here, many of us are here today to try to get a handle on what the future might look like
Yep.
for us and our family and friends and neighbors and what have you, and how to cope with that. But what we're finding is that there's this whole component of private health insurance premiums and the ability not to afford those things, and even for dental care or doing surgery or whatever. And everything, the caveats and reading your strategies and everything, they're all very laudable, they're all laudable. But the truth of the matter is that, isn't it somewhat about the priorities of our society? And, I mean, people can work in the healthcare services as opposed to the tourism industry. I mean, hello.
So, you're asking a really big philosophical question, and so if we were to go around the room and ask people how they think the system should be structured to address that, I imagine we get a range of different answers. And of course, we don't control a lot of that, don't control very much of it at times. But one of the things that I think we do need to be mindful of, Chris talked about it earlier in the presentation, which is that demand growth. And the thing that drives so much of pushing public healthcare into the private sector is that the response from the public sector to growth and demand is not able to keep pace. And so you get situations, and you've seen it in the newspapers here in Southern. If you take something like ophthalmology, where we've had fast-growing waiting lists that we've been unable to address in a timely fashion, and as a result, people have in some cases, have had harm as a result. So you're getting that increasing demand, but not an increased ability to respond. Now, there's a couple of ways you can address that. One is the finding Chris's money tree, but the other is to find ways to divert demand so that those who have no choice can get access to the public system. So if I take my personal example, my wife has macular degeneration. If she wants to get treatment for that at a GP here in Southern, she cannot. She might choose to pay to have that done at a GP and to not have to go to a clinic session in a hospital because she can afford to do it, but she can't access it. If she were in Christchurch, she could. So she would have a choice. If she exercised that choice in Christchurch, she takes a place off the public list and opens it to someone who doesn't have a choice. So part of this system, I think, that's really important is getting our secondary care to look much more at what can be done by other professionals working at the top of their scope, and take some of that demand, shift some of that demand to other places, but not at the expense of people who do not have a choice. If you do it that way, people like me who do have a choice can exercise that or not as we choose. But to the extent that we do, we reduce some of the demand that enables the people who don't have a choice to get access. So I think that's an important part of it.
I had the privilege of being in the Health Select Committee earlier this week, and someone said to me, talked about funding, and I said, hey, look, don't get me wrong, if you want to give us more money, we can gladly use it. And part of the challenge is about part of the challenge is about, yes, advocating to get a fair share of resources for health, absolutely, but within the resources, and this community, the community at Southern DHB is responsible for, gets slightly under $1 billion a year in health resources. Our job is about how do we make sure we best utilise that whilst also advocating for more over time. And then we must go to the chap at the back there too.
Two questions. One, is there really a mandate for increasing the proportion of the funding to public health, health promotion, community development, given you're using all the words of empowerment, partnership, holistic, enabled systems, which are all public health, health promotion, community development, and about connecting people, and given that 96% of the funding nationally goes to the ill health system as opposed to public health. And then secondly, if we think about Margaret, how are we really going to know what matters most to her? And when, what about her, not just her physical needs, but her psychological, her social, and her spiritual needs? Again, given over 50% of what impacts and determinants of health are outside the health system, are those things that we could consider? Use the word holistic, and I'm not quite sure if that's really
Sure. In terms of do we have the mandate, we have the mandate as much as we can grasp it. When we were going out with the wider, earlier stage of the development of a strategy, and we made a comment that we intend on investing more in primary and community services moving forward, I got a stroppy letter from a surgeon saying, how dare you think about investing more in primary and community when there's unmet surgical needs. I go, well, actually, we are the District Health Board. I don't think we were called the District Health Board by accident. We weren't called the District Sickness Board. We were called the District Health Board. And I think we've got an obligation that we have to bring our community along and articulate why it is important that we move more services this way. How successful we are, a huge amount of that will be the reaction of audiences like this, and how you speak about where we're going moving forward. In terms of the, what was the second? I forgot the trail of the second bit. Yeah. So in terms of Margaret, that is the reason why we want the locality networks to not just be health and health providers. So we had an NGO session earlier this afternoon, and they talked about the people that how do we have people like the home and community support providers who are actually in Margaret's home and probably sit down and have a cup of tea with Margaret and really get to know her. How do we get those people involved in influencing where the priorities go so that we can get people, Margaret might be well articulate and may speak up herself, but there are many that won't, and it's about how we get those social agencies and how we get NGOs involved in our locality network and our planning to make sure we become more and more representative of where, so we hear that voice.
Chris Ford, Disabled Persons Assembly.
Yep.
Just in regards to the actual document itself, I've had a read of it prior to the meeting that was scheduled about 2 weeks ago, and I saw in that there were more references, as I remarked to you probably earlier, Chris,
yes, around
disability in that document. But it needs to be more specific, and also in terms of the examples. You talked about the board rather has talked about how the primary and community strategy will impact for Māori, Pacifica, and older people, but there needs to be a section of that I feel on disability as well.
Yep.
But it also very encouraging to hear that the board is considering a disability and health strategy, which is a very, very positive thing that I would encourage that. And I'm looking forward to participating on behalf of the EPA in that process.
Yep.
And as well as that, the other thing is just in terms of what I heard said before around the fact that you're not going to leave people behind who can't access IT or digital technologies to communicate. with healthcare providers, that's very encouraging. How specifically, just to give a quick example, would that work for people who currently don't have access to IT, such as some older people, some disabled people, because they may not be able to physically access the internet, for example? How would that work?
I think there's some really simple examples about, we can't roll out telehealth and make telehealth mandatory. If you can't use telehealth, there's no point offering you telehealth. And so it's about providing those options. And a little bit like Richard's comment about his wife having the option, if you live in Cromwell and we give you the option of telehealth, then great. But if you can't use it and you want to come to Dunedin for your clinic, then you should be able to. Likewise, patient-centred booking. In my view, in my dream state, you'll get sent maybe not even a letter, but you'll be sent a electronic thing. But some people will be sent letters that will enable you to book your appointments online. But actually, there will still be the physical, or ring this number, so that you're empowering and enabling individuals to make the decisions themselves. Clearly, we won't be able to send them an email if they don't have an email address.
Also, in terms of just the digital platforms as well, just ensuring that websites and so forth are fully accessible, and also as part of the disability and health strategy, I guess, talking about how, for example, the disabled people who can access health information and accessible for that, all of that.
Too right.
But I guess this is the first step, but I guess also the challenges to the VHB is that we will be obviously holding you guys accountable.
Yeah. Hey, look, there's a couple of real big challenges there. One is as we get through the planning of the rebuild of Dunedin Hospital, the disability perspective in terms of how we develop and design those facilities is critical. How we develop the website, how we develop the information. I've learnt a lot from Paula, who's on our Community Health Council. Paula is a person on our Community Health Council, a blind lady. She's changed my perspective of lots of challenges and issues that I might have had thoughts in one particular way, and she's kind of blown most of them apart. And it's about involvement rather than presumption. So, yeah.
No, I just want to recollect access to that before she happened to take the going on to one of us to think about it. I'm not looking to that either, but the reality that if she would have the information time with it, we work something, the rules, that's what assistance or the people come in. I'm not looking to that either, because I'm sure that what's going on here, all that poor department, just point of reference back to the primary care, like the GP, is the GP going to be the liaison person for everything, or are we going to have, it's an issue of time, a lot of these people are coming to assistance, but I don't know about time to realize that when they're not having solutions, that would be my concern.
So when Margaret presents at a general practice, the practice team, which is centred around the general practitioner, will determine the future for her in terms of a care plan, who's going to be the key contact and so on. It's important to realise that we're not starting afresh with this process. We've had multidisciplinary teams working in general practice for the last 3 or 4 years. There's a variation between amongst our 83 practices, but it's strengthening. So there will be a key person that will work with Margaret about when she'll interact with her practice. No, it could be within the hub, it could be within, it's as the team in the general practice will determine.
I think that's an important aspect, is that actually my key contact might be a different type of person to Margaret's key contact, and it needs to be tailored to the needs of the individual and the healthcare home they're a part of. I'm going to hand over to Richard to ask you guys a question and make some closing comments.
Well, just before I ask the question, the financial things obviously really important, and I think it was Lord Rutherford that says we don't have the money, so we're going to have to think. And I actually think that that's a really important part of this process. Chris commented about the fact that this is not a strategy that has been put together in a dark room by a group of experts. This is the first. I've been involved in health at a governance level for a long time in this region. This is the first time, I believe, that I have seen the private, the GP community through its PHO and the DHB hand in glove in a change process. And hand in glove in the sense that both boards are totally supportive of the need for not revolutionary change but evolutionary change, and prepared to work together on it. And that really is a very big change. I think the other good thing about not having enough money is we can't actually afford to do this all at once, and that's probably a bloody good thing because we'd probably stuff it up. I think what is really important is that we work our way progressively into this, that we work with initially the people who are ready to go, and we know that across our region we have GP practices who are ready to go, and we know will be sticking their hands up. We know that we've got some rural hospitals who are already operating in many ways similar to this, not always, but in many ways, and will stick their hands up. And so we can work progressively, and if we are successful as we start, we will build a sense of momentum. We do have time. The general practice is not broke, but it faces enormous challenges going forward, and secondary care services face those same challenges, and the interface between them is going to have to substantively change if we're both going to be able to manage those changes. So this is about opportunity, it's about challenge. This is the last now of a lot of these sessions, and most of them have been extremely well attended too, I need to say, and that in itself is really encouraging. So I guess the question that we've asked at each of these sessions at the end is, have we got it right, or are we bonkers? If we've got it nearly right or even half right, but you think that there's some things we're just not grasping here or are missing, we would really, really love to hear from you. We've given you a tight time frame because our experience is that if we give people a long time frame, we probably won't hear. But if we give people a short time frame, we will. What's your sense? Are we on the right track or the wrong track?
Can you answer your own question?
I know what I believe, but we've asked this question at each place we've gone to, because if each place we went to they said you've got this wrong, then we've got to go and rethink it, because we will not succeed if we've misjudged both the community and if we've misjudged the provider's willingness to adapt. I'll diplomatically let Chris answer that.
I'll be up front. It'll be mixed, and some are very keen to be involved, and some won't be. And to be perfectly honest, that will be the same within general practice land. There'll be some GPs who I know, I've already heard from some of them, are itching to get in there with their expression of interest. There will be others who will continue to go on a traditional pathway for a very long time. Our driver is about how we make it an easy option for them to go down this pathway. And I actually think we have to be brave with some of these tough conversations about where we invest our priorities. Otherwise, we'll just keep doing what we do, and we'll end up with 40% of GPs leaving because they retire, and we will not be able, we'll be in a way different challenge in our crisis at that stage, which, frankly, we have the responsibility to make sure we don't get to.
I think it's fair to say that from a primary care practitioner, we do spend a lot of time trying to get our patients into the public system and having to explain to them why they can't get in. And we have the eternal frustration of 5 or 10 letters a day on our desk saying that the referrals that have been sent out, that we've sent, are now not going to be accepted. And then having to waste another hour of our day contacting patients to say that your referral hasn't been accepted and I can't do anything about it. And that's the current state of play, and as Chris has explained, the system is funded to a certain level and each department has made their decisions about access to that. That's the current state of play. I would hope that this system improves that. I mean, that's what we're aiming for. We recognise that's an issue. I don't think Chris would deny that that's an issue, and part of as we come, me as GP, but as the board of the PHO and the commissioners of the DHB recognise that that's not really an acceptable place to be either. There's patients who are missing out on care now that really should have care. And so that's one of the drivers to change the system, is to say, can we actually get better access to care for patients? And we believe that some of the wastage that the system's putting through because of the problems that we're seeing with duplication or all this sort of stuff that's happening can be improved by this system. It doesn't mean that everyone's going to get access for every procedure or everything they ever want. That's just not a reality unless we want to pay 70% tax. And that's the reality of life, and it's not perfect. This isn't, in my opinion, as a chair of the board of the PHO, an effort to try and push people into private healthcare. If that came out from today as something you think that this is talking about, nothing could be further from the truth. This is we're trying to improve the system to make better access to public healthcare.
We published a summary of the health of the strategy in the media recently, and if any of you really want a hard copy, contact my office and said Chris said he would give you a hard copy. We haven't printed it, absolutely we haven't printed it, but if you really want one, contact my office on Monday and I'll get you one.
Do we still have time for questions for you?
Sure.
Like, not talking.
I want to come back to the question. Yes. Not that you got it right, but you're looking in the right direction. I'm a retired GP from the Dunedin. In the past, I've accused the DHB of being a hospital board in drag, not a district court. I think you're looking at whether you can take the drag off.
Yep.
But there's a long way to go, and
Sure.
one of the essentials to have, firstly, to say, any health system that functions well needs a properly funded primary care component. You just need to look at the states to see how it's that is going to be your challenge.
Yep.
And the other thing I want to say is that primary care depends on relationship. And all the electronics in the world doesn't get away from that.
Yep, no, and absolutely. If Nigel Miller, who's our Chief Medical Officer, was here, Nigel Miller's pet subject is health pathways. And often people get confused with health pathways being that electronic thing on the computer. It's not. It's the conversations that happen between general practice and secondary care to develop the pathways, which are really the health pathways, because they're building that rapport and the relationships and the knowledge between each other. It is not just a computer. Martin.
Yeah, I think you're heading in the right direction. I think we don't have time not to act. But my key is act to understand.
Yep.
And then from that understanding, act differently. So I'm sort of optimistic of the fact that we're heading in the right direction. But it will be the feedback that we receive when we act that will inform how we act, if you know what I mean.
Yeah.
And I think we've got a flexibility and an opportunity that if we pass up, it'll be long gone and,
And that's one of the key things. This is a strategy that's going to set the pathway for the next 3 to 5 years. What we're not going to do is get 6 months down the track and go, oh, we've got new priorities. But what we will do is we'll get 6 months down the track, we'll see how things are going, and there will inevitably be some things we do that don't work out the way we thought they would, and so therefore we'll refine, but we'll refine aligned with the strategy and the actions that are in the plan. We won't just go, oh, we've got another priority now. We'll keep going. So,
look, we'll take one more, and then there will be people who need to get away. We're very happy to hang around down here. If there are other questions or comments people want to make, then those who need to go or want to go can, but we're very happy to engage for a bit longer with those who want to stay. We'll take one last question and then we'll bring it to a close, or one last comment, whatever.
As finances, I love you to say, look after the pennies and the pennies and the pennies. So as long as you're careful, and that includes every department, don't pull out too tissue, that would be then when you walk to the toilet, you only need one. If everybody had that mental thought, you'd save an awful lot of money. And I've just one question. Will all the community hubs, and I think that's a brilliant idea, but will it affect the size of the main hospital?
Well, yes, it will, actually, but perhaps not in the way that you're thinking. If we simply continue to do things exactly as we are doing them, then the new hospital is going to need to be 30, 40, pick a figure, % larger. And that in itself will impact on the amount of care that we're actually able to provide, because the bigger the hospital becomes, the more it costs to run, the more it costs to build, the more it costs to maintain, all of those things. So it's a balancing act. One of the real challenges for us in that design is going to be getting that balance right. But as Chris says, if we don't start thinking at this end of the process around the kinds of changes that we can make to take some of that demand out of the hospital and into other places, or prevent it coming in the first place, then the hospital will need to be a great deal bigger. The hospital will not be smaller as a result of this than it is now. We already know that. It will probably actually be a similar physical size, but more efficient, because some of the design of the old hospital doesn't allow efficiency within that same size. So there are things that will enable more to happen in the same floor space. Please don't hold me to that, because that's still to be worked on. But all I'm saying is there's no assumption that this will result in something smaller. We're not going to end up with a couple of MASH tents on Logan Park.
Right. Thank you for that insight, Richard. Look, thank you for your time. And as Richard said, feedback through there, and we're happy to take questions one-on-one if you wish to. But thanks.